Hospital Administration. General Manoj Srivastava graduated from Armed Force Medical College and joined Army on 13th January 1970. He had illustrious career in Armed Force Medical Services, held various prestigious command, staff, and instructional appointments, especially his tenure as DGMS Army Adjoint Director, Medical Services Personnel is remembered very much by his colleagues. And later in the career, he held many other important posts, including Deputy DGFMS, personal additional DGFMS in the office of DGFMS. And as you all know, he was a qualified hospital administrator. He completed his MSc from AIIMS, New Delhi in 1985. And then he held many prestigious posts, as I told you, and he was a renowned academician and a researcher. And above all, he was a founding member and patron of AHA, and was always very happy to contribute in the progress of AHA. Always, he was visionary leader and pioneer in the field of hospital administration, highly respected and hugely admired. Immensely decorated hospital administrator, he will be missed by one and all those he lived in touch. And we can resolve to his honor by continuing to work on the path of excellence as he illuminated by his personal work and ethics. Dear friends, I will request you that we will have 2 minutes silence, and we pray God for his peace of his soul, and then start the session. So we maintain 2 minutes silence. Oh, Shanti, Shanti, Shanti. Thank you, friends. Uh,
So,
I take this opportunity to, welcome Dr. Vijaydeep Siddharth, Additional Professor, Department of Hospital Administration, who is a moderator for today's webinar. And today's topic is self-care for hospital administrators. And I'm really grateful to Professor Ajay Bahl, Professor of Cardiology, Advanced Cardiac Center, PGI Chandigarh, for joining us. Uh, uh, Dr. Vijaydeep will be introducing him. Welcome, Dr. Vijaydeep, and over to you. Thank you.
Thank you, sir. Thank you, sir. Respected Dr. Yashpal Sharma, sir, Professor Ajay Bahl, Faculty Department of Cardiology, and my dear fellow colleagues who have joined this webinar from different parts of the country. Today's webinar is in the series of the webinars which has been initiated by the Academy of Hospital Administration for enhancing the capacity of hospital administrators across the country. I congratulate Academy of Hospital Administration for coming up with this initiative. So today's webinar is on self-care for hospital administrators. Self-care may be, something which can be, defined as the ability of individuals to promote health, prevent disease, maintain health, and cope with illness, which may be with or without the support of healthcare workers. And as we have been reading in the newspapers about the sudden, cardiac deaths, the incidence has increased, and some of our, senior fellow colleagues who've lost their life because of such episodes. So it becomes all the more, prudent for us to take care of ourselves. This is very important for doctors, including hospital administrators. And as all of you are aware that India is undergoing epidemiological transition, and the number and the prevalence of non-communicable diseases is increasing day by day, out of which cardiac illness is one of the major, I would say, the morbidity which is seen in the Indian population. And not only the prevalence is more, but it is a decade earlier in our population. So to discuss this topic, we are privileged to have Professor Ajay Bahl, who is an eminent cardiologist and is faculty at Postgraduate Institute of Medical Education and Research at Chandigarh. He has a keen interest on heart failure, which is a discipline which is close to his heart. He has more than 200 publications, scientific publication in journals of national and international repute, with a H index of 23. Sir, a warm welcome to you, and thank you so much for sparing your valuable time and guiding us, all the hospital administrator across the country. Before I hand over the platform to Professor Ajay Bahl, a couple of requests to the colleagues who have joined. Kindly keep your mics on mute, and we encourage the discussions at the end of the webinar. So I request everyone to make a note of their queries and questions or any clarifications which they have, which will be taken up very warmly by our guest speaker. So thank you so much. With these words, I request Professor Ajay Bahl to kindly enlighten us on, sir.
Thank you. Thank you very much. Thank you for this opportunity. And definitely it is a very important topic. And it's nice to see Dr. Prerak Mittal. He's my batchmate, and he is also, I can see him, or at least I was able to see him sometime back.
He's still here, sir. He's
still here. Yes, yes. But I mean, on my screen, I think only a few can show. So I'll just share my screen. Just a second, please. Can you see my screen if it is all right? Can you see?
Not yet.
Not yet?
Not yet.
Sorry. Just a second, please. Actually, I'll just go back. I'm so sorry. Actually, I'm more. Yeah, now it is here. Share and doesn't. Just a second. Okay, I'll just come back. Can you see my screen now?
Yes, sir.
It is
very
much.
Perfect. Sorry, actually, I'm more familiar with Zoom, so I'm using this after some time. Sorry. Okay. So now we get back to the topic, and basically all diseases, whatever, whether they're infectious diseases or non-communicable diseases, they follow a very similar pattern. And as we know that India is going through an epidemiological transition, and the infectious diseases, as far as cardiology is concerned, the diseases related to infection like rheumatic heart disease are still present in significant numbers, and yet we have landed up with degenerative and man-made diseases like obesity, hypertension, heart disease, and stroke and cancer. So these are becoming relatively important. And as we can see that this is that Broad Street pump, and once the handle was removed, the epidemic of cholera in UK was given in London, that major epidemic that ended. So the same thing, the same principles would apply to these degenerative diseases or diseases of whatever we say of modern living. So as we can see that mortality rates of diabetes, coronary artery disease, and cancers is relatively going up, and those of infections is coming down. Now, what about the same principles apply? Let us look at tuberculosis. The same principle will apply to a coronary artery disease. So when we see that the incidence of tuberculosis over the last 150 years has rapidly been declining, and it really declined in, let us say, the Western countries by the 1970 or so. So why did this decline occur? This decline did not occur because of treatment. The decline or the steep decline had started much before the treatment started. The decline started in the 1840s, whereas the chemotherapy came around 1940 and vaccination came around 1950. So it was a change in the lifestyle or an improvement in the living that caused a decline in tuberculosis. Let us look at another disease, measles. In measles also, when we see the decline started in 1900s, and it was a very, very rapid decline. When did the immunization begin? The immunization began in 1970 when measles had almost disappeared, or it hardly contributed to any mortality in Western countries. So the same principles which apply to measles ideally should also apply to non-communicable diseases. So that is where prevention, or many of these conditions are preventable, or at least these diseases can be postponed to later decades of life. And preventing, there's no age bar for prevention. You can start prevention at absolutely any age, and you would reduce the risk for the rest of your life. And one of the most important determinants of disease burden is lifestyle, and not any new treatment that is made available. So it's the lifestyle changes and the reduction in risk factors that are going to reduce the disease burden of non-communicable diseases, including coronary artery disease. So if we look at the life expectancy at birth, it has rapidly increased in the last 50 years or so, especially in the developing countries. So initially there was a gap of average life expectancy of 35 years between developing and the richer countries, and now this is narrowed to 14 years, and now of course it would have narrowed even further. So what is the burden of coronary artery disease? So we know that almost 2/3 of all deaths are due to non-communicable diseases, and over 1/4 of deaths are due to cardiovascular diseases. And when we look at a specific age group of 40 to 69, almost half the deaths are due to cardiovascular diseases. So this is one area in which we must have a strong preventive action as far as the community is concerned and as far as the national programs are concerned. And out of all the cardiovascular diseases, coronary artery disease and stroke account for over 80% of all deaths. So what is the Indian scenario? There's been an accelerated buildup. As I'll show the data, 30, 40 years back, the incidence of coronary artery disease was very low, and it has suddenly built up over the last, let us say, the last 2 to 3 decades. There is early age of disease onset. The Interheart study showed that the median age of myocardial infarction in South Asians was only 52 years versus 62 years in Europeans. It has a high case fatality rate. Supposing someone has an MI, the case fatality rate is going to be relatively higher because the disease or the infarction is not recognized in time and people do not seek treatment in time. And cardiac rehabilitation is almost non-existent in our country. So the coronary artery disease or cardiovascular diseases are the leading cause of death in all parts of India, including the poorer states and rural areas. So even rural areas have a high incidence of coronary artery disease. In fact, there is a reversal of socioeconomic gradients. 20, 30 years back, it was a disease of richer people, not anymore. Now there is a reversal of socioeconomic gradients, with tobacco use and low fruit and vegetable use is more common in lower socioeconomic backgrounds, resulting in a higher incidence of coronary artery disease. Individuals from lower socioeconomic background frequently also do not receive optimal therapy, leading to poor outcomes. And the ICMR study showed that 50% of all adult Indians fall into the category of physical inactivity. That means it's not even mild physical or a low grade of physical activity. They would be classified as physical. Their lifestyle would be classified as physically inactive. So prevalence of coronary artery disease in India has rapidly increased. In 1960, the survey showed the prevalence was 2%, and this has increased to 14% by 2013, and now it probably is even higher. It has more than quadrupled even in rural areas, so 1.7% to 7.4% between 1970 and 2013. So one of the largest studies looking at the epidemiology of coronary artery disease or acute myocardial infarction was the study. So this was a cohort control study, and it had around 15,000 cases of acute myocardial infarction and 15,000 age-matched controls. Out of this, a significant number, or over 10%, were from South Asia. So what the Interheart study showed was that the high incidence of coronary artery disease is not due to some great genetic factors or some due to very different factors or due to a different population. The risk factors in Indians were the same as any other population. In fact, the risk factors in every single population in these 52 countries were identical. And there were just 9 factors that were responsible for over 90% of the heart attacks worldwide. The risk factors were the same in absolutely every population. Each one of these 52 populations had the same risk factors. And these were abnormal lipids, smoking, diabetes, hypertension, abdominal obesity. These were the 5 major risk factors. So abdominal obesity also got added as a major risk factors. We already knew that lipids, smoking, diabetes, and hypertension are major risk factors. In addition to that, there were some other factors also that contributed to coronary or myocardial infarction. These were psychosocial factors, low fruit and vegetable consumption, low alcohol consumption. Well, this is a little controversial, and low physical activity. And this was true in every population, including South Asian. So Indians, high risk, but the risk factors were absolutely the same, what was seen in any other population. So what was unique in Indians? They had a very low prevalence of protective factors. The protective factors were regular physical activity and fruit and vegetable consumption. So these two were lacking in Indians, and they had a higher prevalence of abnormal lipids, diabetes, and abdominal obesity. So there were 2 factors which were reduced, and these are the factors that we can actually work on. And if we work on these 5 factors, we'll be able to reduce the burden of coronary artery disease and delay the onset of coronary artery disease in the Indian population. So what the Interheart study showed was that if we take care of just 2 factors, tobacco and abnormal lipid ratio, we can explain more than these explain more than 2/3 of the risk, and just targeting these 2 will have a huge implication for the Indian population. So tobacco, change in diet, and increase in physical activity. So what do you think is the burden of hypertension in India? 1, 5, 15, or 30? Well, it's extremely high. Prevalence of hypertension in adult Indians was 30%, high in both urban as well as rural areas. Urban was 34%, and rural areas was 28%. So what about diabetes? In urban areas of India, the prevalence of diabetes has almost doubled from 9 to 17%. In rural areas, it's increased from 2 to 9%. So there's been a massive increase in diabetes. And in addition to that, a much larger population has pre-diabetes. And the risk of coronary artery disease in pre-diabetes is almost as much as what it is in diabetes. So a very large percentage of population is at risk because of diabetes. So what is the best time to target diabetes? For women, it is very simple: gestational diabetes. If a woman gets gestational diabetes, This she is at a very high risk of developing diabetes in future, developing cardiovascular disease in future. So this is a red flag indicator. This is the best time to intervene. Once she has delivered, intervention at this time, we must motivate that woman that she must intervene at this time, change her diet, change her lifestyle, and this can prevent or delay diabetes. Even delaying diabetes by 10 years will reduce the cardiovascular risk, and it will markedly reduce the lifetime burden of cardiovascular disease. And the reason for this is that any woman who develops gestational diabetes, 1/3 chance of developing diabetes and 1/3 chance of developing impaired glucose tolerance. So 2 out of 3 women are at high risk of cardiovascular disease or coronary artery disease in future. So gestational diabetes, red flag mark, treat it as a serious event and intervene, and one will be able to reduce the cardiovascular disease burden. So this is something that in women, at least, we can identify high-risk women relatively early. So what about lipid abnormalities? In fact, an ICMR study showed that only 20% of Indians had all lipid parameters which were within normal limit. The most common lipid abnormality in Indians was low HDL, and it was more often found among those with lower levels of education. So early life influences in Indians are also important, and this is known as the first 1,000-day hypothesis. So this starts from the time of conception through the first 2 years. And this has been implicated in the onset of cardiovascular disease and risk factors during adult life. So maternal malnutrition results in placental insufficiency, and the resulting fetal programming has been hypothesized to be associated with low muscle. So if the mother has malnutrition, the fetus will have low muscle and a high fat body composition. So this is what is called as a thin fat child, that even though the body weight is low, there is a high fat content, there is a reduction in the beta cell mass and fewer glomeruli in the kidney. Rebound obesity and weight gain. I'll just take a second. Sorry, this is barking in the back. I'm so sorry. So rebound adiposity and weight gain during childhood. So these children who are thin fat children, the children who have a lot of fat but their actual body weight is low, they have a rebound adiposity and weight gain during childhood between the age of 2 to 12 years, and they are at a high risk of developing diabetes as young adults, diabetes or impaired glucose tolerance as young adults. So the InterHeart study showed that the usual cardiovascular risk factors are important in Indians. However, these risk factors occurred at a younger age. And what was the reason for this risk factor occurring? It was basically the lifestyle. It was not some genetic factor or something like that. And this lifestyle can definitely be changed. So the risk factors in Indians increase exponentially once the age of 30 to 39-year age group is reached. So what was seen was that younger individuals, let us say people in the 15s, 20, 25 years of age, these risk factors were not so prevalent. But the moment Indians reach the age of 30, these risk factors exponentially start increasing. So this is the age when we should target individuals to reduce their future risk. So metabolic syndrome is extremely common in Indians. And again, it's a lifestyle disorder. It is due to insulin resistance. It's associated with abdominal obesity, diabetes, hypertension, high triglycerides and low LDL, and with heart disease. So what is abdominal or central obesity? So abdominal or central obesity is basically an increase in intra-abdominal fat. This fat is located inside the peritoneal cavity and packed in between internal organs as opposed to subcutaneous or intramuscular fat. So the subcutaneous and intramuscular fat is not so much of a risk factor. It's the intra-abdominal fat that really contributes to developing a metabolic syndrome and coronary artery disease. So this is defined as an absolute waist circumference of more than 40 inches, easier to remember than 102 centimeters in men and 35 inches in women, and a waist-hip ratio of 0.9 in men or 0.85 in women. So again, what is abdominal obesity? So a person who has a paunch, who has abdominal obesity, may not be overweight. His weight may be normal or he might be just overweight. So this is what is known as a thin fat, even though the overall weight is not much, but the distribution of the weight puts this person at high risk for a metabolic syndrome. And this can occur this is a risk factor at all ages, both genders, and abdominal obesity is a risk factor across the world. We must know that anyone who has inflammatory disorders like rheumatoid arthritis or a chronic infection is a major risk factor for atherosclerosis. So anyone who has an inflammatory disorder, one should take precautions and prevent coronary artery disease in future. So how does one prevent a coronary artery disease? Step one is know your risk. This is it. So each one of us must be aware of the risk, and this is what has been targeted in almost every Western countries. If you ask a person, he will know his risk of having a coronary artery disease in the next 10 years or so, or a lifetime risk of coronary artery disease. So there are multiple multiple apps which are available, or multiple calculators which are available. These are online. So this is the US calculator. This is by the American Heart Association. Europe has its own calculator. In fact, Europe has 15 different calculators, the European Society of Cardiology, for 15 different regions of the European Union. And Britain has its own calculator. So the British calculator apparently is the most reliable as far as the Indian population is concerned. But the American Heart Association or the American College of Cardiology risk calculator is available. This is available both as an online tool as well as an app. So carrying out systematic studies is very important. And Framingham, we know, is a very small town in the United States, carried out a systematic study, and we learned a lot from this study. What Framingham Heart Study taught us was valuable lessons. This shows how important is it to carry out systematic studies. It told us that smoking, hypertension, and high cholesterol contribute to heart disease. And today this is taken for granted. But then we got this information only from this study. Before Framingham Heart Study was carried out, this high cholesterol with coronary artery disease was not really linked. Even hypertension with heart failure and as well as cerebrovascular disease, this relationship was not known. So I think we also need to have some good cohort studies which are long-term perspective in our country. So now know your risk. So this is one of the risk calculators of the American College of Cardiology. You feed in all the given parameters, which include the age, sex, the race, systolic blood pressure, diastolic blood pressure, the lipid profiles, diabetes, smoking status, hypertension treatment. Statin, aspirin is no longer very important because aspirin nowadays has not been shown to reduce coronary artery disease unless a person has an MI or unstable angina. And this will ultimately give you a risk. It will give you a number. And this number there'll be two numbers which come out of all these risk calculators, whether it is the ESC risk calculator or the HA risk calculator. And these are the 10-year risk, the risk that one will have over the next 10 years, and the lifetime risk of having coronary artery disease. So what about the ESC risk? So we have seen the American College Cardiology. What about the European Society Cardiology risk factor? So what it says is that these are all for primary prevention. I'm talking about people who do not have established coronary artery disease. People who have established disease are to be considered at high risk. So apparently, this includes people of less than 70 years of age, as well as more than 70 years of age. And there are two different risk scores which are available. For younger than 70 is a score 2, and for more than 70 is a score 2 OP, which gives the 10-year risk of fatal as well as non-fatal cardiovascular disease. So it is a class 1 indication. So if we look at every single guideline, it tells us that it is important that every single individual in the population must be aware of the risk of coronary artery disease or a cardiovascular disease over the next 10 years. And it's so important because more than 1 out of 4 individuals are going to die of coronary artery disease. So any patient who has established coronary artery disease or diabetes, so diabetes has been given the same status as established cardiovascular disease, moderate to severe kidney disease, severe lipid profile, or uncontrolled hypertension are also each one of, if any of these risk factors are there, these individuals are to be considered to be at high or very high risk, and suitable preventive measures are to be taken. And with the preventive measures, the risk can be very significantly reduced or markedly reduced. Now, do these risk scores apply to Indians? So when you feed in either the European Society Cardiology risk score or the American College Cardiology risk score, would they apply to us or not? So if we look at the European Society Cardiology guidelines, what they say that if a person is of South Asian descent, multiply the risk by 1.3 for Indians and Bangladeshis. So if we get it for a white individual, you get a risk of 5%. We need to multiply it by 1.3 for an Indian or a Bangladeshi. Multiply by 1.7 for Pakistanis, and for other Asians, multiply by 1.1. So Indians are definitely at higher risk for coronary artery disease with the same risk factors. And the reason for that is possibly that these risk factors start appearing at a younger age. So the lifetime exposure to these risk factors for Indians is relatively higher as compared to those in the Western countries. So what are the diseases when we talk of these risks? What are the diseases which are covered in the risk? That means these are fatal or non-fatal myocardial infarction, angina or heart failure, stroke or TIA, fatal as well as non-fatal transient ischemic attack, peripheral vascular disease, and aortic atherosclerosis resulting in either a thoracic or an abdominal aortic aneurysm. So this risk score, all these calculators will give the 10-year risk of all these conditions put together. So it's important to know your risk. So, and one must know that what is the general risk and be aware of the general risk of coronary artery disease or cardiovascular disease over the next 10 years. So let us take a 40-year-old individual, absolutely healthy. He has no risk factors. Blood pressure is 130 by 80. His LDL is normal. HDL is normal. What is his 10-year risk going to be? His 10-year risk of having a cardiovascular disease is only 1.1%. But look at this figure. His risk, lifetime risk of having a cardiovascular disease is 36%, right? And the reason for that is that cardiovascular disease is responsible for majority of deaths. So 10-year risk is low, but the lifetime risk is high. Now the same person reaches the age of 50, no risk factors, blood pressure 130 by 80, normal lipid profile, without any risk factors. With just a few extra birthdays, he has reached the age of 40 to 50, and his 10-year risk is now 3.4%. The lifetime risk, of course, remains the same. When the same individual without any risk factors reaches the age of 60, his 10-year risk reaches 8.7%. Of course, age, which clearly shows that age is a very major risk factor, and individuals who do not have any risk factors, as they age, their 10-year risk of coronary artery disease or cardiovascular disease, myocardial infarction keeps on rising. So the moment you cross the age of, let us say, 50 or 60, even without any risk factors, the 10-year risk is significant. And the important part is that it is today very easy, or it is possible to reduce this risk very significantly. Of course, age is something that one cannot reverse, and that is a major risk factor. Now, we go back to the same slide. There's a 60-year-old individual, no risk factors. His risk over the next 10 years is 8.7%. So now let us suppose he develops diabetes mellitus. What is his risk? His risk has doubled from 8 to 16%. So diabetes doubles the risk. The coronary artery disease that a person with diabetes will be more diffuse disease, and the outcomes will be relatively worse. But again, in diabetes also, coronary artery disease is relatively preventable. So 44-year-old person, no risk factors. We had already said the risk is 10-year risk is 1.1%. He starts smoking. His 10-year risk, even at the age of 40, is 3.6%, and his lifetime risk increases to 50%. So very high. And if he quits smoking, his risk immediately drops in between. It drops to around 2.6%. So risk assessment, these numbers are very imperfect. We have to realize that we can't take this 2.1 or 5.6 or something as absolute figures. because these are affected by ethnicity, by social and economic factors, and the severity of and duration of risk factors. So we do not take the duration of diabetes, the severity of diabetes, how well has the blood pressure been controlled. All these have not really been taken into account when we look for these risk factors. So these have to be modified. Let us suppose the diabetes, you get a risk of 5%. Diabetes is very long-standing severe. I would make the risk a little higher. So who should be screened? So as per the American Heart Association, it should be every individual 20 to 75 years of age. And these people must be aware of the risk. If you are aware of the risk, you can do something about it. The European Society of Cardiology recommends that even above the age of 70, that means no upper age limit, the risk should be, one should be aware of the risk. And this risk is to be repeated every 4 to 6 years. Now, if we look at the risk calculator, the American College Cardiology risk factor, the 10-year risk score comes in individuals from 40 to 75 years. So 20 to 40, you will not get a number, but you will just generally know that which part of the risk profile you are in, low risk, intermediate risk, or high risk. You'll know the number of risk factors you have, but this 10-year risk is only for individuals. The number that you will get is only between the age of 40 to 75, and the lifetime risk indicators between the age of 40 to 60. So what about, we have screened an individual, 50-year-old, he has no risk factors, he falls into an intermediate risk category. So does he need any drug, like let us suppose control or lipids and all? How do we decide that? So there are some risk enhancers which are available. So apart from the 9 major risk factors, there are risk enhancers that are available, and these include family history. Anyone with a strong family history of premature coronary artery disease, that means coronary artery disease in a first-degree relative, less than 55 years of age if a male, or less than 65 years of age if a female, then a coronary artery calcium on imaging, a high CRP, a lipoprotein A, and a waist-hip ratio. These are things that can help us in deciding whether to give a statin in addition to lifestyle modification or not. So these risk enhancers, that means they are applicable to individuals who have a borderline risk, where one is not very sure whether we need to intervene with a statin or not. So in those individuals, we can put in these additional factors. So the single strong risk factor, for example, a strong family history or heavy smoking, may result in underestimation of risk. So this is one of the drawbacks of all these risk calculators. If the risk factor is very strong, multiple family members are affected, then the risk is likely to be underestimated in a given individual. So as per the American Heart Association, low risk is less than 5%. 5 to 7.5% is borderline risk. And this is where we can use the risk enhancers. So the coronary artery calcium score, this is the ideal population where we would do a coronary artery calcium score, where we can take a call whether to start a statin or not to start a statin. And anyone above 7.5% is considered at intermediate, or basically this is high risk as per the European Society of Cardiology, and people who have more than a 20% 10-year risk are considered at high or a very high risk of cardiovascular disease. So these two groups, anything above 7.5%, one should intervene. So as per the American Heart Association, statins are to be given if the 10-year risk is more than 7.5 to 10%, or a lifetime risk is more than 39%. And they significantly reduce both the 10-year risk as well as the lifetime risk. But before we start drug therapy, the most important thing is lifestyle modification. We must realize that Indians get coronary artery disease at a younger age, and metabolic syndrome also at a younger age. And the reason is lifestyle. And lifestyle modifications can delay the onset of all the risk factors. So one is, we must encourage physical activity started at any age. We should recommend at least 150 minutes of exercise per week if it is moderate intensity, or at least 75 minutes per week if it is vigorous intensity physical activity. So 150 if moderate exercise, like let us say a brisk walk or something. And if we are going to do a vigorous activity, then it should be at least 75 minutes per week. Mediterranean or similar diet. So this is nothing except a high fruit and vegetable diet. Increase in fruits, vegetable, legumes, nuts, soya products, and whole grain. Avoid sugars. Eat fish, preferably fatty fish, at least once or twice a week, and restrict processed meat. Oils, which are relatively good, have high amount of monounsaturated fat and omega-3 fatty acids. And these include the oils which have high content of monounsaturated fats are mustard oil, rice bran oil, canola, soybean, walnut, and flaxseed oils. So one of these should form the primary oil. That means around 60-65% of the oil should be one of these. And the remaining 30% can be a little bit of desi ghee or maybe one of the other vegetable oils. The problem in India is that palm oil is very commonly used. I don't think anyone uses it at home, but palm oil is one of the cheapest oils, and any food which is cooked in palm oil doesn't get spoiled very easily. So whenever you go out and eat, likely that it is cooked in palm oil. All the packaged biscuits or whatever the packaged products that we get, many of them are in palm oil, because palm oil is probably the most commonly used oil in India. So likely that if you eat packaged products, you're eating palm oil, and this is not a healthy oil. This is completely a saturated, it has complete saturated fats. The other thing is to restrict salt to a little more than a teaspoon a day, less than 6 grams salt or 2,400, which corresponds to 2,400 milligram of sodium. So a teaspoon or just a little more than that per day. Restrict alcohol consumption to a maximum 100 gram per week, and smoking cessation is an important factor. So if we just change our diet and increase our exercise, we would be significantly reducing our risk of coronary artery disease. And we must remember that it is these lifestyle changes, or it is these lifestyle of lack of activity and a poor diet that has contributed to a large extent of Indians getting coronary artery disease 10 years earlier than the Western population. So that is one. So lifestyle changes must be done. And the other major intervention that is available to us is controlling the lipids. So it's all lifestyle and statins. These are the two factors that will reduce the risk. So the drug of choice is statin. In case the statins do not achieve the goals, we can add ezetimibe. PCSK9 inhibitors are expensive, given subcutaneously, so they are injections. And recently there have been some controversy about the PCSK9 inhibitors. So I think the mainstay today depends statins and ezetimibe. And in case the lipids are not controlled, then one can consider adding PCSK9 inhibitors if we do not meet the goals. So what are the goals of LDL? And this is very important. If the risk of coronary artery disease in future markedly reduces. So a person who has got an established coronary artery disease or a cardiovascular disease, there should be a decline of LDL of at least 50%, and the target LDL is only 55. So if you look at all the reports, what is normal LDL? Reported as less than 130. So any person with established cardiovascular disease, the goal of LDL is really low. It's less than 55. And I'll come to this later, that why is this number of 55 so important? Anyone with diabetes with target organ damage, again, these individuals are at very high risk of coronary artery disease. The target is still the same, greater than 50% reduction and less than 55, a target of less than 55. So any diabetic more than 40 years of age, if we target a LDL of less than 70, the risk of cardiovascular disease markedly goes down. So any diabetic over 40 years, LDL target is 70. So if we change the lifestyle and we meet the LDL targets, we can markedly reduce the incidence of coronary artery disease. So supposing a person develops a coronary artery disease, does a coronary plaque regress? That means can that plaque regress? And this has been very strongly correlated with LDL levels. So LDL level around less than 65 to 70 will stabilize the plaque. That means the plaque will not increase in volume, or even if it increases in volume, that increase is very small. It may be more than not more than 1 or 2% per year. For plaque regression, that means for the plaque to actually reduce in volume, we need to keep the LDL less than 55. If the LDL is more than 55, that plaque will not regress. So there are good studies using intravascular ultrasound which have shown that if we get the LDL below 55, there is some regression of the plaque. So what about diabetes? Diabetes, we must remember there are two aspects to it, and this is what we keep trying: maintaining a good good glycemic control, maintaining your HbA1c, maintaining the blood sugars. We must remember that a good glycemic control only reduces the risk of microvasculopathy, that means eye disease, nephropathy, but macrovascular complication, that is coronary artery disease and stroke, the reduction is relatively modest, or there's just a trend. There's not much reduction in macrovascular disease. So for cardiovascular disease reduction and diabetic, what are the methods? Exercise. Ensure other risk factors like hypertension and smoking are controlled. Control of a good diabetic diet, and meeting LDL goals. And just these are the factors which will control the cardiovascular disease or coronary artery disease in diabetics. There is no other way that one can reduce coronary artery disease in diabetics other than meeting LDL goals, regular exercise, and giving up smoking. A person who has diabetes and smokes, the risk of having a coronary artery disease and acute myocardial infarction is extremely high. So what about LDL? What about individuals who are healthy? When do we start a statin? So if the LDL is more than 190, this is extremely high, and we rarely encounter individuals whose LDL is more than 190, then definitely this LDL has to be reduced. The lifetime risk of a person with LDL of more than 190 developing a coronary artery disease is more than 90%. So, and we must also modify other risk factors, which is basically exercise, diet, smoking, and hypertension. If the risk is less than 5%, then probably we do not need to intervene. If the risk is between 5 to 7.5%, we can consider statins, or we can add another risk enhancer. We can test another risk enhancer like CRP, or let us say a coronary artery calcium. If these are positive, then one can start a statin. Otherwise, we can observe them, and I mean, this 5.7.5 5 to 7.5 10-year risk is a borderline area where the guidelines are a little controversial, in the sense they give a little leeway either way about starting or not starting statins. The lipid, because of the high risk of coronary artery disease in Indians, the Lipid Association of India has recommended that start statins in low risk individuals if the LDL is more than 130. So the Indian guidelines say that, if we remember the Western guidelines, they said 70 and 55. So very high risk individuals, established disease, we keep the LDL below 55, and individuals with diabetes or other major risk factors, we keep it below 70. The Indian guidelines say that high or very high risk, keep the LDL cholesterol below 50, and individuals who are really at very high risk, who have had multiple, let us say, myocardial infarctions or multi-vessel disease, keep the LDL less than 30. But I think these are very difficult to achieve without PCSK9 inhibitors. So why are we only talking of LDL? Why not triglycerides, a high triglyceride level and a low LDL and a low HDL level? These definitely enhance the risk. So someone who has high triglycerides and a low HDL has a metabolic syndrome and is at significantly increased risk of a coronary artery disease. However, targeting these does not reduce the drugs. So multiple drugs have been tried. I've just named two, niacin and fibrates. Over multiple trials, if you try to lower the triglycerides or increase the HDL levels, the risk is not reduced. The only way to reduce the risk is by regular exercise and dietary modification. That can result in a risk reduction in patients with high triglyceride or low HDL. So now there is a lot of people do not start statins because of the fear of side effects. So clinical trials have shown that 1 to 2% of individuals have statin-related muscle symptoms, that is muscle ache, tiredness, and they're not able to carry out their usual activities. But with high-dose statin therapy, when we look at the general surveys out of the clinical trial, that means population-based studies, it is seen that around 10% have muscular symptoms. So in case an individual has muscular symptom, we can try to switch over to a different statin. So if somebody say atorvastatin, we can switch over to rosuvastatin. There is another concern about glucose tolerance. Yes, Glucose tolerance does occur, intolerance does occur in some individuals who are taking statins, especially high dose statins. But overall, the risk reduction, despite this increase in glucose intolerance, the cardiovascular risk reduction of statins is still very significant. We must remember that statins are practically the only drugs that really reduce the cardiovascular risk. And there is a variable response to statin. That means somebody has an LDL of 130, you give same 10 milligram atorvastatin, in one individual it might come down to just 110, 120. In another individual, it would come down to 150. So whenever we start a statin, after 6 to 8 weeks, we should repeat the lipid profile and then adjust the dosage accordingly. Hypertension, we know, is a silent disease. For every known person with hypertension, there are 2 individuals with undiagnosed hypertension. Hypertension does not cause any symptom in the vast majority of individuals. Around 90 to 95% of hypertensives will have no symptoms. So unless the blood pressure is measured, they will not be aware that they have hypertension. Only around 5 to 10% individual complain of some headaches or some vague symptoms like palpitations and all. So it's important that the blood pressure be measured every 3 to 5 years in every individual. So what are the blood pressure targets? The first objective is that we should achieve a blood pressure of less than 140/90 all individuals. And this gives the maximal benefit. If the individual is 18 to 69 years of age, we should target a blood pressure of around 120 to 130. Above 70 years of age, we should be a little careful. We should definitely target below 140. And if there are no postural symptoms, if there's no giddiness, we can target around 130. But then we have to be careful because there's risk of falls if we lower the blood pressure or we cause postural hypertension. In all treated patients, preferably the diastolic blood pressure should be lowered to less than 80 millimeters of mercury. What about coronary artery calcification? Now, this is a very commonly carried out test, and the reason is that it's a simple test. It's just a CT with a very, very low radiation dose. So that is why it's commonly carried out. Calcification is a feature of atherosclerosis. It was even found in many Egyptian mummies. In fact, 1500 BC, the Egyptian mummies, around 1500 of them, they were subjected to a CT. And out of the Egyptian mummies, 50% of them had coronary artery calcification. So, and they were relatively young, around 45, 50 years of age. So, and I'm sure 1500 BC, they must have eaten an organic diet. There were probably no processed food. So even at that time, coronary artery disease was fairly common. So what is the ideal age of screening for coronary artery calcium? It is 40 to 65 years of age. As I have shown that above 65 years of age, everyone is at risk, relatively high risk of coronary artery disease, which warrants starting a statin. If the statin levels are, let us say, above 100. So the ideal age is 40 to 65. Less than 40 years, one usually does not do a coronary artery calcification study because at this age, the plaques are soft, they are non-calcified, and let us suppose the coronary artery calcium study is negative, then it gives a false sense of security. So it is useful in individuals with low to borderline risk to decide on statin therapy. If the score is 0, one may avoid statin. 1 to 99, any coronary artery calcification, one should start statin, and depending on different guidelines, score to 100 to 300, one must start a statin, right? We must remember that coronary artery calcification is a risk modifier. A 0 score is not 0 risk. A 0 score reduces your risk. Let us suppose your risk, if as per the AHA calculator, is 3%, if the coronary artery calcium score is 0, it would reduce the risk, but it would not make the risk 0 because a number of myocardial infarctions occur because of soft plaques which may not have calcium. So as far as treatment is concerned, it is prevention with lifestyle modifications and statins. This is the only thing. And control of risk factors like smoking, weight reduction, reduction in salt intake. So it's important to emphasize, Indians have an early onset of coronary artery disease, which is largely a lifestyle disorder related to physical activity and the diet. So measures taken early in life are far more effective in reducing the lifetime risk. So let us suppose we start a statin of 5 milligram at the age of 40. The overall risk reduction of this 5 milligram statin would probably be more than a atorvastatin of 40 milligram started at the age of 60. So measures must be taken as early in life as possible, but at whatever age of life these risk factors are reduced, the 10-year future risk is going to be significantly reduced. So it's never too late to reduce the cardiovascular risk. To summarize, cardiovascular disease is a major cause of morbidity and mortality. Many risk factors are preventable. Most important is know your risk and act on these risk factors. I think every individual must know that what is his risk over the next 10 years and what is the lifetime risk. These are lifestyle diseases. To a large extent, they are preventable and they can be significantly delayed. The solution is prevention. It is lifestyle plus statins plus, in addition, control of risk factors. We must know that all diseases, tuberculosis, measles, and possibly even coronary artery disease, the disease is going to go, or the mortality due to the disease is going to reduce much before good treatments come into being. Of course, if a patient has a myocardial infarction, early treatment, early percutaneous intervention is going to markedly reduce the risk. But when we look at the population level, is the risk factor control, which are important. Most important of these, the one that is most easily controlled is abnormal lipid. That is, we must set an LDL goal and we must act on it. Quit smoking. Diabetes is preventable, or one can easily delay it by early lifestyle modification, and statins are as important or probably even more important in diabetes as good blood sugar control. Hypertension, so low salt and control the blood pressure. Abdominal obesity, psychosocial factors, low fruit and vegetable consumption, moderate alcohol consumption, and low physical activity. These are issues that must be addressed. Thank you very much.
Thank you, sir. I must compliment you on a very comprehensive and a lucid presentation, and you made the topic look so simpler when it comes to a complicated topic like cardiovascular diseases. So you have very comprehensively covered that. I would just lay emphasis on certain key points, like the Indians are at a higher risk compared to the Western and the European population. And the one of the things which you have very nicely emphasized is that these are all modifiable. But it's not something which cannot be something which cannot be undone with the lifestyle modification statins, and most importantly, the assessment of the risk factor at the right age and bringing the intervention at the right time. So with this, I'll open the house for any questions. And I'll request everyone to raise their silent hand for getting your queries answered from Professor Ajay Bahl. So what I'll do, I'll begin with a very small query which I have and which people usually have in their mind. You mentioned about modifying the lifestyle by certain moderate exercise or vigorous exercise, which you mentioned that 150 minutes per week should be the target if you're doing some moderate exercise, and 75 minutes per week if you're doing the vigorous exercise. So is there any minimum duration of this exercise when we take it as cumulative, or how do we assess that whatever 150 minutes is there is in one go, or breaking them into smaller, maybe 30 minutes or 20 minutes? How do we make sure that this is effective, what we are doing, sir?
Actually, for exercise, unfortunately, there are a number of studies and there is a lot of contradiction. So this 150 per minute, 150 of moderate exercise and 75 minutes of vigorous exercise is what the American Heart Association, this is the minimum exercise
that's the minimum.
The guideline as far as breaking up the exercise is concerned, the only one society, even the European Society Cardiology doesn't give it, only the Canadian Society has given the breakup. And what they say is that exercise at one time ideally should be at least 20 minutes if you are doing a moderate exercise, and at least 10 minutes if you are doing a more vigorous exercise. Right. So it's 150 minutes spread over a week. And but if you look at the diabetic associations, they recommend around 40 minutes a day, 5 days a week. So that is a little more exercise. So there is still some controversy, but even to reduce the cardiovascular risk, this much is enough. So it's 20 minutes of moderate at one go and 10 minutes of vigorous exercise at one go. That is as per the Canadian.
Right. Thank you so much. So one more query which I have from my personal experience, that whenever we walk or we do a brisk walk or light jogging, there is a fluctuation in the heart rate which happens, which might go from 90 to 165. So is there some limit on that? That where do you need to stop when you start worrying, or is it fine, sir?
If you are healthy, there is absolutely no limit, because if you do a treadmill, treadmill is done in a controlled environment.
Sir.
So it depends. I mean, in a treadmill, you are expected to reach at least 85% of your target heart rate. So target heart rate is 220 minus age.
Right, sir.
So a person who is physically very active, he'll reach around 85-90%, and he'll take several minutes to reach it. Whereas a person who is not active, who's not used to doing physical exercise, in the first 2 minutes, he'll reach his full target heart rate.
Okay.
So
Right.
there is absolutely nothing to do with your target heart rate.
Right, sir.
Once you start exercising on a regular basis, you'll find that your heart rate doesn't go up that rapidly.
Right, sir. That's, and one more thing, sir, which the you have emphasized in your talk about the role of statins, and as what I could get from your talk is that as early the statins are introduced, the more beneficial it is. So you suggest that maybe an assessment should be done at the age of 40 to 49 years, and if introduced early, these can be very beneficial, sir.
Yeah. No, actually, the recommendation is that do the first lipid profile at the age of 20, or whenever is the first medical contact after the age of 20. So at the age of 20, unless the lipids are very abnormal, it's okay. You control your risk factors. At the age of 40, what you can do is that you can look at the 10-year cardiovascular risk. If the 10-year cardiovascular risk is more than 7.5% over the next 10 years, you must start a statin, because it will significantly reduce that risk, very markedly reduce that risk. If it is between 5 to 7.5, it's considered borderline. If that risk is less than 5%, then there's no need to start a statin unless the lipids are very markedly deranged.
Right, sir. Are there any questions from the audience who are attending online?
Thank you, Professor Ajay Bahl. It was really a wonderful presentation, and I must compliment you for making it so easy for us to understand. You rightly pointed out that almost 1/3 of the deaths are because of NCDs, and there is a lot of focus on Niti Yog on nowadays on the NCDs, and a lot of working groups are there who are in the process of making the recommendations for the country. In India, you said that the disease, especially the cardiovascular diseases, there's early onset and high case fatality, which is worrying, and cardiovascular diseases are the major cause of death. You very nicely explained that these are lifestyle diseases, these are preventable, and we must know our risk. Especially, you told about the apps and tools and calculators for calculating the one's risks, and immediately how to act on the risk factors. I mean, wonderful presentation. I have also one question. This question, a lot of people keep on talking about it. Like, after the COVID, people say that there has been, lot of increase in the MIs, especially in the young. Is that a fact, or just a myth? Because but I personally feel that this. Yes, you also told that the uh, death in early age, MI in early age is very common. But nowadays, everything is being attributed to the COVID pandemic. Is there any correlation?
So regarding COVID, well, the data is a little contradictory. The only hard data is available from the UK. In UK, there is this is for sudden death. I'm not talking about MI, I'm talking about sudden death. So in UK, there is a rule that any sudden death is autopsy is mandatory. So somebody has a sudden death, 100% individuals will have an autopsy. So that gives a very, so not a single sudden death is missed. It's a comprehensive 100% data of the entire country of at least England and Wales, where they have autopsies of 100% individuals who have had sudden death. In that, they have not found any increase in either myocardial infarction or incidence of myocarditis in their autopsy sample. So not even as there is no increase. So pre-COVID and post-COVID, there was no change in sudden deaths, in the incidence of sudden death per whatever 1,000 population or a lakh population, as well as no increase in myocardial infarction or even myocarditis. Myocarditis, a lot of, or even thrombosis post-COVID. But I think all of us have seen individuals who have developed, let us say, thrombosis at least, which have occurred both COVID vaccination as well as post-COVID infection. So ICMR is currently carrying out a study to answer this question. It has just been started. So maybe in another year or two, we will have this data, but I guess the increase is not very dramatic. Even if the increase is there, it's only a slight increase.
Thank you.
So thank you so much, sir, for your wonderful talk and sparing your valuable time. I thank you sincerely, and I thank all the audience who have joined on Saturday afternoon, and especially Professor Ajay Bahl, who must be very busy, but he spared his time. And thank you so much. So with
Thank you
this,
so much.
we'll close this webinar. Thank you so much. Thank you all.
Thank you, Dr. Ajay. Thank you very much.
Thank you.